We are live.
Good. Good evening, postgraduates, and my namaskar to all the mentors. Welcome to this 122nd episode of our AIS ARC PG teaching program. Today, we will be having a journal club. Journal club is the thing, it is a signature of our PG teaching program. We are very proud to have this particular program, and we are really indebted to all the mentors and the discussants, senior discussants who come and join and help us in creating, or rather, I should say, reinventing the journal club, which is going into in many of the institutes not being followed. So, with this short introduction, I would request today's moderator, Dr. Tinku Bali, to carry forward the proceedings. Over to you, Dr. Tinku.
Hello, good evening, everyone. First of all, on behalf of the entire organizing team, I would like to wish everyone who's present here this evening a very Merry Christmas. Well, it's heartening to see such enthusiastic academic interest even on a festive evening. Christmas is all about sharing gifts, and today our presenters will be sharing something equally meaningful, that is knowledge, evidence, and clinical insight. They'll be critically analyzing two very pertinent and important journal club articles and telling us how they fit into our clinical practice. So, with that, I welcome all the presenters, all the mentors, our panel of discussants, and also all the audience that is there with us this evening. A very warm welcome and thank you so much for being with us this evening. With that, I'll give you a quick introduction to our panel of experts. We have a very distinguished panelist who will be taking the discussion forward after the journal club, after the journal articles are discussed by the presenters. We have with us Dr. Sanjeev Mittal, who's professor and head of the Department of Ophthalmology at AIIMS Rishikesh, a very distinguished clinician, academician, and researcher. Very warm welcome to you, sir.
Thank you. Good evening.
We have with us Dr. A.K. Grover, who's the chairman of the Vision Eye Center and senior consultant in the Department of Ophthalmology at Sir Gangaram Hospital, New Delhi. Welcome, sir. Sir is a world-renowned authority in the field of oculoplasty, and he's also the president of the Ocular Trauma Society of India. So he's just the right person to give us inputs on these articles. Welcome, sir.
Thank you. Look forward to the discussion.
Thank you. Thank you so much, sir. We were also had invited Dr. Rupesh Agarwal from the Nanyang Technological Institute at Singapore, but he's indisposed, so he couldn't join us. So with that, we'll start with the proceedings. And our first presenter would be from Shankar Dev Nethralaya, Guwahati. And her mentor is Dr. Sangeeta Kalata. Dr. Sangeeta Kalata is a consultant in the cornea, cataract, and refractive services at the Shankar Dev Nethralaya, Guwahati. So it's my pleasure to invite Dr. Vidushi Dikshit to share her slides. Dr. Vidushi will be sharing very interesting journal articles, that is Boston Type 2 Keratoprosthesis, the midterm outcomes from a tertiary care center in India. Over to you.
Ma'am, am I audible and visible?
Yes, you are. Loud and clear. Yes. Perfect.
Good evening, everybody. I'm presenting a journal which is titled as Boston Type 2 Keratoprosthesis Midterm Outcomes from a Tertiary Eye Care Center in India. This was published in the Ocular Surface in 2019, and it was authored by Dr. Geeta Iyer et al. We have used the MARI framework to analyze this journal, which would comprise of methods, assignment, assessment, results, interpretation, and extrapolation. This was a retrospective study conducted at Sankara Nethralaya and Chennai, and it analyzed midterm outcomes in 10 patients who had undergone type 2 Boston keratoprosthesis. It comprised of 10 patients, 6 females as opposed to 4 males. And this is the first report on Boston type 2 K-Pro outcomes from outside of United States, and therefore it provides us valuable insights and future outcomes in dealing with end-stage ocular surface disorders. So this is a retrospective study conducted at Sankara Nethralaya, Chennai, in the period of February 2013 to June 2017. They have analyzed 10 eyes of bilaterally blind patients with a follow-up of at least 6 months or more. In this we have implanted Boston type 2 keratoprosthesis, and primary outcomes were measured in the form of an anatomical retention or functional vision of these patients. The secondary outcomes were to analyze the post-operative complications. The inclusion criteria was patients having an end-stage ocular disorders, bilaterally blind. Baseline or mean age of these patients were 46.7 years, ranging from 22 to 75 years, comprising of 6 females and 4 males. In patients where this technique was either modified or patients which failed to fit the criteria of a minimum 6 months of follow-up were excluded from the study. The indications for implanting type 2 keratoprosthesis was Stephen Johnson's in 8 out of 10 patients. 1 patient had ocular cicatricial pemphigoid and 1 patient had a chemical injury. So a little bit brief about how this K-Pro is implanted. This is implanted preferably under general anesthesia. In case the patient is unable to go through general anesthesia, we can also do this under local anesthesia by adding sedation to the patient. Axial length was determined based on the B-scan ultrasonography. Hereafter, lid sutures were taken with 4-0 silk sutures. The conjunctiva was retracted. We have implanted the Feringa ring, and here thereafter mark the host cornea with for more than 8 mm. We then take a donor cornea and refine it for more than 8.75 millimeters, and then the recipient cornea is defined at 8.25 millimeters. Thereafter, we assemble K-Pro, and we have to ensure that the protruding nub of this K-Pro faces anteriorly. Then we have to do extracapsular cataract extraction. We then secure this K-Pro using 1690 Vicryl sutures. Then K-Pro is, after suturing the K-Pro, we have to implant Ahmed glaucoma plate to deal with the glaucoma. In the upcoming slides, we will see how detrimental it is to manage glaucoma in these patients. Patients have to undergo a total pars plana vitrectomy. After the vitrectomy is done, the glaucoma tube is inserted at the pars plana. Then the globe is formed using the saline. This slide comprises of how we close this case. So lid margins, we now have to suture the lids together. So the lid margins are extirpated and all the hair follicles and lashes are removed. The skin is sutured in 2 layers. So the subcutaneous layer is sutured using 7-0 interrupted Vicryl sutures, whereas the skin itself is sutured using 8-0 nylon sutures, which can be secured with a bolster. Then after this, a notch is cut around the optic of the K-Pro. And once this is done, a peribulbar triamcinolone injection and moxifloxacin injection separately are given at the end of the surgery. Coming to the assessment part, pre-operatively, all the patients were checked for PL and PR, whether it was positive. A B-scan was done for the posterior segment analysis, and a digital IOP was recorded. A patient underwent a type 2 K-Pro surgery and a pars plana vitrectomy with Ahmed glaucoma valve. However, in 1 patient, there was already a retinal detachment surgery that had occurred earlier. So in this patient, silicone oil removal and silicone oil reimplantation was done. A follow-up was done monthly for first 1 month, and then 3 monthly for the next subsequent follow-ups. At every follow-up, the BCVA, the disc, IOP evaluation, and a B-scan was done for the patient. Coming to the outcome definitions, this study defines outcomes into 2 parameters, whether it was anatomical success or a functional success. Anatomical success would It is basically defined if the retention of the primary keratoprosthesis was there or not at the end of the follow-up. And functional success was defined if whether the patient was able to gain an ambulatory vision, which was BCVA better than 20/200. This study gave encouraging results, wherein 90%, that is 9 out of 10 patients, gained a self-ambulatory vision and had a dramatic improvement in their quality of life. 8 out of 10 patients achieved excellent visual outcomes with a vision of 20/30 or better than this. These visions remained stable for 7 out of 10 patients. However, 3 patients, out of which one had a glaucomatous optic atrophy, one had a complication of retroprosthetic membrane, and another patient went into endophthalmitis. These 3 patients could not gain a very good visual outcome. Other patients maintained a vision of better than 20/200. The implant itself proved to be highly durable, and the retention rate was significantly high, with a 90% retention rate in this given in this study. 9 out of 10 eyes did not need a revision of this implant. However, one patient developed a retinal detachment, and thereafter the surgery was done and the K-Pro had to be re-implanted after a sterilement. Comparing this study to the other similar studies, we have 2 more studies similar to this, authored by Pujari et al., Lee et al., and our current study. So a BCVA of 20/200, which was maintained, this number was 31% in the first study, 37.5% in the second study. But the study that we are now analyzing has a 70% of patients, shows 70% of these patients having visual acuity better than 20/200. BCVA better than 20/50. This was 24.1% in the study published by Pujari et al. And 60% in the current study. Retention of primary K-Pro. This was somewhere about 50% in the other 2 studies, whereas the current study shows it to be 90%. What is really remarkable in this study is the management of glaucoma. In the study conducted by Lee et al., most patients had 72.9 had pre-existing glaucoma. That is, 72.9% patient had a pre-existing glaucoma, and this was owed to patients undergoing earlier corneal procedures and had glaucoma due to it. However, in this study, only 10% patient had pre-existing glaucoma. Progression after the surgery was not noted in the current study, which was noted in the earlier study. And no patient developed a glaucoma after the undergoing keratoprosthesis. This could be in the paper, in the article, this article, they've said that this might be due to in most patients who have undergone keratoprosthesis in the current study have mostly not undergone any other corneal procedure. So to analyze which patients will need this surgery is also equally important. Patients showed an improved results. 9 out of 10 eyes gained a visual acuity of better than 20/200, and 8 out of 10 them showed excellent results, having a vision of better than 20/30. 7 out of 10 eyes maintained this vision. However, 3 patients could not maintain this vision. 9 out of 10 eyes retained the primary device. 1 patient could not, and as per the Kaplan-Meier survival curve, functional success was reported to be at 85.7% at 5 years, and anatomical success at 60% at 5 years. We now discussing the complications. One patient developed membranectomy. One patient developed a retroprosthetic membrane and had to undergo membranectomy. For one patient, 2 patients had to undergo skin revisions. 1 patient developed a retinal detachment. He had to undergo retinal detachment surgery followed by a K-Pro exchange. This was the only eye in which the primary K-Pro was not retained. One eye underwent a sterile melt. Endophthalmitis was noted in one eye. In one patient, there was a pre-existing glaucoma. However, no progression or no new glaucoma developed in the patients who underwent K-Pro. Complication rates comparing this to the other studies was significantly much lesser in the current study. As opposed to Lee et al., wherein the retroprosthetic membrane rate was 60%, this study had only 1 out of 10 patients who developed it. Sterile melt, again, was noted in only one patient as opposed to 39.6% in Lee et al. Skin revisions, 52.1% of the patients had to undergo skin revisions in the study earlier published. However, in the current study, only 20% patients needed a skin revision. So this is the patient who had to, in whom the primary K-Pro could not be retained, wherein the patient developed retinal detachment and a transcutaneous retinal detachment surgery was done for this patient. Thereafter, after the surgery, a perioptic sterile melt was noted, and therefore this K-Pro, the primary K-Pro had to be taken out, and a new K-Pro had to be implanted. So the strengths of the study is a high retention rate compared to the earlier studies, a better functional maintenance, and a low glaucoma progression. And limitations would be that the sample size is rather small, and this is only a midterm follow-up of 2.75 years, and that the study is in a retrospective design. Boston type 2 K-Pro is viable for Stevens-Johnson syndrome and other end-stage ocular disease in Indian patients as well. And lower complication rates, as shown in this study, show a favorable future for this entity. However, we do need a larger study, a prospective study, and long-term studies for this. And this study highlights the importance of multidisciplinary care for the patients involving all specialities, including cornea, retina, glaucoma. And patient counseling and compliance is extremely important, as the follow-up can go as frequent as monthly or 3-monthly. And there are lesser number of studies in this part of the world, so there is still a chance that this is an opportunity that we can get more number of studies for this device. The future directions would be that these findings from developing country, they highlight the potential for widening for successful adoption of this type 2 keratoprosthesis. A longer term follow-up or on larger cohort is necessary to confirm these findings. The take-home message would be that Boston keratoprosthesis shows rather encouraging results, and there are excellent visual outcomes as shown in the study, that wherein 90% of the patients have been able to achieve a self-ambulatory vision. The device retention rate was 90%, and the breakthrough glaucoma control is something that's just remarkable. And there is a favorable complication profile, given that there are lower rates of retroprosthetic membrane, lower rates of sterile melt, and lower rates of skin revision as compared to other cohorts that are done earlier. Thank you.
Thank you, Dr. Vidushi, for that very expert analysis of the article. You highlighted all the pertinent points extremely well and also told us how it can be clinically applied to our practice. So congratulations to you. With that, I'd like to get in Dr. Sangeeta Kalata. Dr. Sangeeta, I'd just like your views on why you chose this article, and what do you feel are some important points that you would like to highlight before we move on to the discussion.
Yeah, because of the novelty of this technique and the documentation from India, this was the first documentation from India about Boston keratoprosthesis type 2. So though we have two devices, like we have two surgeries, comparable surgeries like MOKP and Boston keratoprosthesis type 2, and both we can do in end-stage procedures, end-stage ocular surface disorder. But what is important is that in MOKP, most of the patients, they go through it is a multi-stage procedure. And because of this multi-stage procedure, in some patients who are edentulous, and in some patients who are who are high-risk patients who cannot go ahead with general anesthesia. In those patients, we go ahead with Boston keratoprosthesis. Also, this is a midterm outcome, visual outcome study. So in all other studies like Lee et al., they have a longer outcome, longer visual outcome, the longer follow-up they have. But this is a midterm follow-up outcome we have. This is the novelty of this article is that. And thirdly, another thing is that because of this, we need more studies in this part of the world. So there are lesser studies in this part of the world, so it is difficult to compare the outcomes of these patients. So we need to go ahead. We have also started recently this Boston keratoprosthesis type 2, and we have done 2 till now. So last year we have done 1, and this year we have done 2. We have faced lots of challenges during the custom clearance and the device which is coming from the Boston. So from my side, if we can develop this keratoprosthesis in India itself, we can also think about that.
Yes. Yeah, very well highlighted, Dr. Sangeeta. Dr. Vidushi, I
Because in
request you
both
to.
the cases, in my first case, so I have faced 4 months. 4 months it has taken for the device to reach Guwahati, and in my second case, it has reached. It has taken 6 months. So to reach for the device to reach Guwahati. So why not we can innovate something? We can develop this keratoprosthesis type 2 in India itself. Orolab, they usually they make a keratoprosthesis type 1, but type 2 is very difficult to procure.
Okay. So thank you, Dr. Sangeeta. Dr. Vidushi, I request you to stop sharing your screen, please.
Yes, ma'am.
Yeah, thank you. And before we move on to the discussion, we are privileged to have with us Dr. Rupesh Agarwal. So, Dr. Rupesh Agarwal, welcome. A very warm welcome to you. So, Dr. Rupesh is an associate professor at the Lee Kong Chian School of Medicine at the Nanjing Technological University, Singapore. Dr. Rupesh has a special interest in uveitis and ocular trauma, and he's been an office bearer of multiple ocular trauma societies in the past. So, very warm welcome to you. And with that, we move on to our discussions. Dr. Grover, sir, what would be your inputs on this article?
I think the choice is good because it introduces the postgraduates to a subject which is difficult, which is important. The options that are left in an eye where the more viable procedures like a limbal stem cell transplant or a limbal transplant or a cultivated stem cell transplant is not possible, then you are left with very few choices. So in a difficult situation like that, you still have options for the blind who have lost bilateral vision following a devastating Stevens-Johnson syndrome or ocular cicatricial pemphigoid. The choices exist. It is important for postgraduates to know and to know the techniques that are used and that work reasonably well. And they must also understand the difficulties that are involved. So I think the analysis of the article was good, and she had pointed out the strengths, the weaknesses, and analyzed all the aspects of the article. But the one thing that was mentioned as strengths of the article was not the scientific strengths, were the strengths of the results themselves, that the results were good. The strength of the article essentially does not mean that. What you need to stress is that this is on a subject which is which has not been published from anywhere other than US. So it is important that some results have come from outside. The series is reasonably large for a subject for a procedure which is very rare, which is very rarely done, and 10 is a reasonably large cohort for that. So I think that is the strength of this, which explains why those weaknesses which have been pointed out in the weaknesses of it being a retrospective study, of being a relatively small size, are taken care of by the strengths, that this is a rare subject, that this surgery is rarely done. And in the article, the surgeons point out that they have done another 7 or 8 in the subsequent year, which has not completed the minimum follow-up time. So they are doing it well because they are getting good results, and they will be able to publish an even larger series. I think all in all, a good introduction to a difficult subject about the design of this particular Boston keratoprosthesis 2, which differs from keratoprosthesis 1, which can be used in those with more favorable situation. So I think the one reason why it has not been manufactured in India is because the numbers are so small, and devising a device which will be used for very few is not economically viable. So if the surgical procedure becomes relatively more common, then it can become economically viable for a company to produce it. So these are some of the aspects that I can highlight.
Thank you
Thank
so
you
much,
so much,
sir.
sir.
Thank you, sir.
Dr. Sanjeev, I would like to request your perspectives on
Yes,
this.
actually, what Dr. Ashok Dover sir had just told, and I just concur that actually the study is good, like Indian study is done, but the research question actually is not very clear since this has already been done, and the outcome parameters have been actually correlated with the inclusion criteria, and which differ actually with the previous studies. So that comparison is not actually that appropriate one, but we expect. But however, there's a good introduction to this article, this topic, and good knowledge, and more actually articles and more long-term studies would be really helpful. So that's great.
Thank you so much. And now I invite Dr. Rupesh Agarwal for his inputs and perspectives on this article. Dr. Rupesh.
Thank you. I think thanks first of all to Dr. Bhawankule and AIS for the opportunity. And apologies, I'm not well, though probably I'll try and speak slowly. First I was not able to attend, but somehow managed to kind of join. But thanks. So I think wonderfully presented. I like what she presented, and I think it was very swiftly presented with this. So I'll probably, because they have asked me to comment, and already Dr. Grover has very comprehensively covered all the points. So just to add certain points. So if you go back to your presentation, in the surgical steps, you are describing as if you are the one who is doing surgery, but it is the surgeons who have done. So when you describe, you have to just say the surgeons or the authors have done. It's not that you. So most of the slides, what you were mentioning that we did this, so it's not we, is that surgeon which have done that. So that's something which I noticed in a few of your slides when you were in there. I think you have to just say that thing. And of course, there's quite a lot of information. So sometimes when you're presenting, again, you have to kind of cut short some of the information. You might not be able to present the entire information about it, all this information, whatever is needed. Now, to draw attention to go into the detail, you pointed out about glaucoma. Everywhere else you mentioned about the number of eyes having complication or the good outcome. But in glaucoma, you only written percentage. And if you convert that percentage into number, you written 10% of the patient with glaucoma, which seems like a big number. But actually it is 10% of 10 patients, which is equivalent to one patient. So only one patient. And then in one patient, when you have to say that they did not progress to worsening of the glaucoma and all, it is going to be very difficult to say that. So I think there you have to be very careful when you draw percentage in the studies with a smaller number. So as Dr. Grover said, it's very important to have such studies. But at the same time, when you draw conclusion, particularly in terms of percentage, you need to be careful. So you need to be seeing what need to be mentioned in percentage, what need to be mentioned in number. So I'll probably restrict myself to the number and then don't draw. Now, Kaplan-Meier is a very powerful statistic tool. And typically, I don't know whether you know much about Kaplan-Meier. And one of the things about all these papers is, can you drop Kaplan-Meier because it gives you a long-term survival. So there are certain things in Kaplan-Meier. One is the number of years, the number of follow-up events it has happened. So it is a good that the patient had a follow-up for 5 years. So it gives you at certain time points. It also should be able to tell you whether there are a number of events which has happened at each time point. So number of events in this term is typically the Kaplan-Meier started with a life survival, life analysis, whether it is death or a life. So here the death or a life means, is it a success or a failure? Success in the terms of visual success or visual failure, or anatomical success or anatomical failure. So one of the two you have to choose. So when you draw Kaplan-Meier, you have to choose either 0 or 1. So 0 is good outcome, and good outcome is 660 or better, whatever you want to call it, as 636 or better. And worse outcome is worse than 660. So you got that. Now, at each event, at each time point, when the patient comes back, at each time point, whenever there is a dip which happened, let's say the vision goes down to 660, so there is one event which has happened. So every single time point, whenever you measure the Kaplan-Meier data point, so there is a dip. When the dip happen, that means that many number of events has happened. So that become powerful. So typically, Kaplan-Meier is drawn based on the power of a study. So I think authors were a little super ambitious in drawing up it for a 10 patient. So it might not be the right statistics to use in this kind of a context. So that also you could have pointed out in your extrapolation about was that the right statistical tool, because that might not fit. So you have already given nice about the visual success and the anatomical success, which is good enough in this thing. But here, Kaplan-Meier, at least you need 30 or 40 patients or 100 patients. So 10 patient might be good, but sometimes not good enough for this thing. So that's one of the thing. I like your extrapolation about it. So one of the other things sometimes which you can do when the sample size is smaller, let's say 10. So something which you can try and do, and particularly we have been trying to do, is do up a bit of a pooled analysis, systematic review meta-analysis in case if it's possible. So you compared 1 or 2 studies. So you can try and see whether if the same technique has been done in US or in Europe or in Australia or somewhere, and then you pull up those numbers and then drop with that thing. So it's a pooled analysis, which is under systematic review meta-analysis. And if you can do that, it will make up into a bigger study. So you can use the same work which you have done under the guidance of Dr. Sangeeta, who has very nicely supported and very in the right direction. And with her 3 cases and this 10 cases from this review, and maybe 3 or 4 good studies from the literature, you should do a next step is a systematic review meta-analysis, which will form a very formidable idea about what should be the future direction of such a novel procedure. Is it moving in the right direction? And that is where you can answer some of the unanswered question, which is difficult to answer in rare procedure like this thing. So that will be my one of the advice to you, and you should try and publish it early by mid next year, before next WOC or something. Target it under guidance of Dr. Sangeeta, and also take into consideration other co-authors who have published similar work, and with that publish a larger series in Survey of Ophthalmology or one of the journal. That will be the nice for Indian ophthalmology, and that will be a proud moment for AIOS to celebrate. So those are some of my points. But
Thank
very
I
you.
would
well
Thank you
like
so
to
much,
ask
sir.
Dr. Rupesh Agarwal, sir. So for sir, smaller sample size, like this type of rare surgeries. So what is the analysis that statistical analysis you would suggest?
Yeah, so not many. There are 2 types of statistics broadly you divide. One is the descriptive statistics. You just describe whatever the failure and all. So that's a simple one. You just put up a percentage failure rate and all. Now, if it comes to the correlation analysis, so you can do this correlation analysis using chi-square test and all those standard tests. So simple univariate analysis, which is the bivariate analysis model, you can do it. Multivariate, if you are really looking into multiple variables, which is looking into the outcome, then you can do it. But other than that, you can't do many different analysis as far as the smaller number is concerned, unless you pull in more number of patients and then you try to apply Kaplan-Meier. But Kaplan-Meier in a smaller thing, it might give you results, but not the best fitted statistical test for a smaller number. Yeah. So maximum is the bivariate analysis, which is chi-square or Kruskevich test, and depending on what kind of statistics you are trying to analyze. So those are the only correlative analysis which you do, because there is not much of correlation you want to do. You're just trying to present your observational study and you are just trying to present your results. So that's something, what is a research question? Here you're not trying to compare 3 or 4 different techniques, then you start doing it. You're just trying to present your results using the Boston Cape, which is a relatively novel. And then a simple descriptive statistics also should be good enough. You know, you don't have to go into it. Right, Dr. Grover? Right.
Absolutely.
Thank you, sir.
Dr. Agarwal. Thank you, Dr. Agarwal. Just before we move on, what is the Singapore perspective on the use of this keratoprosthesis? Is it equally difficult to procure, and is it popularly?
So I'm not into this thing. SNEC does that. My hospital does not do it. So I'm in Tentoxin Hospital, which is the second largest hospital. Other 2 hospitals are Singapore National Eye Center and National University Hospital. So Singapore National Eye Center have been doing it, but they are not doing it very commonly. So they also find it difficult to procure. So I'm sure Jodhbir Mehta will have more inputs. He has developed some more techniques. So if Dr. Sangeeta or Dr. Vidushi, if they want to get into contact with Jod is a dear friend, and I can connect, and he can give more idea about what they are doing. And if they want to come for some attachment observership also, we can arrange that with Jod there at SNEC. So he's the current leader in this thing. But because I'm not into this space, I'm more in uveitis, so I'm not exactly aware. Because I do know from Jod's research work, there are some artificial cornea work and other thing he's doing. But current status of this, as far as, so probably I'm not the best person to answer.
Okay. Thank you, but for those excellent inputs and pointers that you gave about how to go about analyzing the study. And with that, we move on to our second journal article. So this article is on the clinical features, management, and prognostic factors of traumatic optic neuropathy, another very relevant and pertinent article. The mentors for this article are Dr. Suresh Kumar, who's professor and head at the Government Medical College and Hospital, Chandigarh, and Dr. Tanu Singh, who's assistant professor at the Government Medical College and Hospital, Chandigarh. And presenting this article is Dr. Rajshri Singh, who's a senior resident in the same institute. So I invite Dr. Rajshri to share her screen.
A very warm good evening to all. Today, I'm presenting a journal club on the clinical features, management, and prognosis factors of traumatic optic neuropathy. The article is currently in press in the Survey of Ophthalmology journal, which has an impact factor of 5.9. To begin with, traumatic optic neuropathy is a severe complication that can cause permanent vision loss or blindness. Traumatic optic neuropathy results from primary optic nerve injury, followed by secondary processes such as axonal edema, hypoxia, and ischemia. And the reported incidence of TON is 1.5 to 2% after head trauma and 2 to 5% after maxillofacial trauma. The diagnosis is based on history of trauma, decreased visual acuity, relative afferent pupillary defect, abnormal VP, and a normal fundus. TRON is often underdiagnosed or undertreated due to prioritization of life-saving interventions. As for the lacunae in existing research, there's no consensus on optimal treatment, as reported success rates for interventions vary widely. Also, there is insufficient information regarding the prognostic factors and incidence of other ocular and extraocular symptoms. Therefore, this study provides the largest and most comprehensive systematic review of traumatic optic neuropathy to date, analyzing 6,068 patients and 9 prognostic variables. As for the methods, the study followed PRISMA guidelines and synthesized all available epidemiological and treatment evidence on traumatic optic neuropathy. A systemic literature search was conducted in PubMed, Embase, and Ovid from inception to October 2024. Search terms focused on traumatic optic neuropathy and optic nerve injury and trauma. As for the inclusion and exclusion criteria, Eligible studies included human studies, interventional and observational clinical studies, which had at least 5 traumatic optic neuropathy patients, and full text availability. Excluded studies included reviews, meta-analysis, editorials, abstracts, technical notes, animal or cadaver studies. Study selection and data extraction were performed independently by 2 reviewers. Study quality was assessed by the Newcastle-Ottawa scale for the non-randomized studies and the Cochrane criteria for the randomized control trials. Evidence quality was graded using the GRADE framework, and statistical analysis was done using the R software. For the results, 2,768 records were retrieved through the literature search, of which 1,292 unique records were screened, 169 full-text studies were reviewed, and 109 studies comprising 6,068 patients were eligible and included in the analysis. On analyzing the demographics, it was seen that traumatic optic neuropathy predominantly affects males, amounting to 84%, wherein nearly half of the cases involve the right eye. Young patients are commonly affected, with 43% under 25 years of age, and road traffic accidents are the leading cause, followed by falls and assault. And most patients receive treatment within 3 days of injury. As for the clinical features, nearly half of the patients present with no light perception at onset. Immediate vision loss after injury is common. However, 35% experience progressive visual deterioration. And severe RAPD grade 4 was present in almost half of the cases. Optic canal fractures are frequent, detected in 34% on CT and 47% intraoperatively. And traumatic optic neuropathy is strongly associated with craniofacial fractures. And intracranial lesions are also common, most oftenly ethmoid or sphenoid sinus hemorrhage. The treatment and prognosis was based on these 9 prognostic variables, they being baseline visual acuity, pattern of vision loss, presence of optic canal fractures, treatment delay, salvage optic nerve decompression surgical technique, preoperative steroid pulse therapy, hemorrhage within ethmoid or sphenoid sinus, and the state of consciousness before treatment. As for the general efficacy, in general, treatment effectiveness ranks as 66% for endoscopic transethmoid optic canal decompression, 61% for intravenous erythropoietin injection, 56% for optic nerve decompression, and 48% for steroid pulse therapy, all of them outperforming observation overall. However, the inferences deduced for the endoscopic transethmoid optic canal decompression and IVO erythropoietin injection needs to be inferred with caution because they were based on a very few number of studies. As for the stratified efficacy on the basis of baseline visual acuity and pattern of no light perception, in patients with no light perceptions, outcomes of optic nerve decompression and pulse therapy were limited and not superior to observation, while EPO performed best. In patients with residual vision, optic nerve decompression and steroid pulse therapy and EPO were all effective, with EPO showing the highest benefit. However, the pattern of no light perception onset holds limited prognostic value in the management. As for the stratified efficacy on the treatment delay, earlier treatment, that is within 7 days, significantly improved outcomes of optic nerve decompression and steroid pulse therapy, especially in no light perception patients. And in the presence of optic canal fractures, optic nerve decompression was superior to steroid pulse therapy. However, without fractures, both treatments were similarly effective. As for salvage optic nerve decompression, it benefited 51% patients, and greater efficacy was seen in patients who had either a residual vision or they were without an optic canal fracture. However, for the optic nerve decompression technique, preoperative management with steroid pulse therapy, the hemorrhage status, or the loss of consciousness, all of these did not markedly change the outcomes. For the strengths of the study, this is a first comprehensive meta-analysis covering the demographics, clinical features, management, and prognostic factors of TON. This is the largest pooled cohort to date, improving the statistical power and the reliability. Also, the extensive subgroup analysis of 9 key prognostic variables was done, and the study provides a high-level evidence to support clinical decision-making and patient counseling. However, for the limitations of the study, the majority of the studies were retrospective observational. Also, there was high heterogeneity across the studies due to difference in design, treatments, and outcome assessments. Also, there might be a potential spectrum bias with underrepresentation of mild or subclinical traumatic optic neuropathy cases, and there is a lack of standardized imaging protocols and surgical reporting across the studies. To conclude, traumatic optic neuropathy mainly affects males, most commonly due to traffic accidents. There is severe vision loss, and it is often associated with craniofacial fractures. Optic nerve decompression is more effective than steroid pulse therapies in patients with optic canal fractures. However, in patients without optic canal fractures, optic nerve decompression and steroid pulse therapy have similar efficacy. And early treatment is crucial, especially for patients presenting with no light perception. Assessing the article along the MARI framework. For the methods, the study is a well-designed, PRISMA-compliant meta-analysis with robust statistical methods, and conclusions are limited by heterogeneity and predominance of non-randomized data. As for assignment, the study includes a large representative TON population dominated by young males, enhancing the external validity. And for the assessment, outcome assessment is clinically relevant but limited by non-standardized visual acuity measurement and functional visual outcomes. For the results, active intervention improves outcomes over observation, especially in patients with optic canal fractures and early presentation. For interpretation, findings support selective rather than routine intervention, emphasizing baseline vision and timing. And for the extrapolation, findings are extrapolatable to the real-world TON practice in trauma centers, but they should be guided by baseline vision, optic canal status, and timing, rather than as a uniform treatment recommendation. Thank you.
Thank you, Dr. Rajshri, for that excellent insight into traumatic optic neuropathy. Before we move on to the discussion, I'd invite Dr. Tanu Singh, who is an assistant professor at the Government Medical College and Hospital, Chandigarh, to give her analysis of the article and any other relevant points that you would think pertinent. Dr. Tanu.
I'd like to add my 2 cents to it. So as we understand that most of our tertiary centers, we cater to a lot of trauma patients, and the diagnosis of TON is one of an important cause where patient ends up having a visual loss. So as this article very rightly highlights the importance of a good clinical examination, which not just helps to identify this disease entity in time, it also helps to prognosticate the case. Another important point that was highlighted was the role of CT, which should ideally be ordered very early in the course of the disease, because it will help us to pick up any direct cause of a traumatic optic neuropathy, where optic nerve decompression, as we see, tends to have a better visual outcome when compared to other treatment modalities. A few limitations that I would see is like there is lack of consensus as far as the treatment protocol is concerned for indirect form of traumatic optic neuropathy. There are a lot of modalities, but there is lack of clarity regarding the dosing or the regimen that needs to be followed for these cases. Statistically, as we see, many of the parameters that were analyzed show a lot of heterogeneity. So that would certainly affect the level of evidence that the article is trying to put up, and that probably might be related to the more observational and retrospective study design articles that were included in the analysis. Also, the article overall helps to give us a good insight as far as the clinical features, the prognostic parameters, and the management protocol that needs to be followed. However, there is no consensus as to the preferred treatment modality that needs to be followed for the indirect variety of traumatic optic neuropathy. So probably this treatment strategy needs to be customized for each individual patient, and every patient should be analyzed and treated as per the way the patient is being presented, be it the direct or the indirect form of traumatic optic neuropathy. I would like to ask for the insights of all the panelists that's here that have come here to share their views and their experience, because there are a lot of gray areas as to even the steroid pulse therapy that we have to give for traumatic optic neuropathy. There are different doses that's been given. There are also different regimens that's being followed. So what in your experience tends to work better for the traumatic optic neuropathy, more so in the indirect variety of the traumatic optic neuropathy?
Dr. Tanu, another thing I noticed was the use of erythropoietin. So could you highlight how that works, or have you been using that in your practice? That was something new.
Not been using. What we use in our clinical practice is essentially the pulse form of steroid therapy, where we give IVMP 1 gram loading dose for initial 3 days, followed by 11 or 14 days of oral steroids. So again, like for steroid therapy in itself, there are various permutation combination that people have been following, where they give pulses only for 3 to 4 days. Then people, few of them tend to combine oral and intravenous form of steroids. The erythropoietin has something that has come new actually, and the dosage that they recommend is around 20,000 international units for initial 3 days. So it basically tends to improve the blood flow, and it targets the various receptor bound. And so all the 4 studies that have been presented, 3 of them have just shown the efficacy of erythropoietin. So they have not actually compared it with steroid or optic nerve decompression, except for one article which has tried to compare it with the other two form of treatment modality that's there. But then again, the data is limited. So the role of erythropoietin say still, it's very early to say that it is the treatment protocol that we need to follow blindly. I have not done it personally, so I would also.
We'll move on to our discussants and the panelists and ask them their opinion on this. So, Dr. Sanjeev, what would be your perspective?
Yeah, I would say like this article is really has a great significant clinical application. And we know that there are limitations in trauma cases because of most of the patients are trauma cases, and the life-saving measures becomes a priority. So hence, like what Dr. Taru also said, like this happens, we are all assuming this pulse therapy of steroids, methylprednisolone, that's we are trying. And of course, like with this article, actually, this narrates about that, like there's a fracture of the optic canal, one should actually resolve to the decompression part. So those things actually should be emphasized more. That's true. And erythropoietin, I don't have an exposure to that, no experience, we are not using it. Like we'll see to it, but we have not used it, no experience.
Dr. Grover, sir, what would be your inputs on this article?
So first thing that the study was presented well, it was a good choice because it is an area which remains very hazy, and a meta-analysis of this order where such a large number of studies and such a large number of cases have been collected is a major benefit to the audience to listen to all the possible therapies and their possible strengths. But the real answer could have come only with a multicentric prospective study, which was in fact attempted about a couple of decades ago, and AIMS being one of them. But it had to be dropped midway as enough cases were not collected. So as of now, the analysis was good, MARI analysis was done, and the strengths of the study and the interpretation were all discussed very well. But the fact remains that all the results that come from a study like this, as has been pointed out, a meta-analysis like this, have to be taken with a lot of caution, because, as was explained, the methodologies for surgery vary, the dosage for use of intravenous steroids, pulse therapy, they vary. The timing at which it was done vary in different studies. The duration since injury was variable. So there are a lot of gray areas within this analysis, which tell us that we need to take all these results with caution. Although a trend in a large meta-analysis like this can be a pointer, but then we need to exercise a lot of caution. The fact remains that as of now, there is nothing established as a therapy. And as was noticed, even the observation group had 34% of the cases improving. So improvement in about 50% with the pulse therapy, or about 55% with the surgical group, does not mean that much. And then again, whether the therapy was instituted within the first 3 days, first 7 days, what is the right time beyond which the therapy may not have an effect? All these are questions which do not have an answer and are looking for an answer. So I think someday we'll trust Rupesh to come up with a multicentric study again to answer some of the questions which remain a very hazy area for all of us. Good study gives us some pointers.
So on that note, we move on to Dr. Rupesh Agarwal. Dr. Rupesh, what do you think about this?
Thanks. I think congratulate Rajshree and Dr. Tanu for identifying this study and picking up, and I'm glad AIS is supporting this. So this is one of my favorite topic, and I think really good. So I've been trying to do similar study, though there is no conflict of interest here, and one of the colleague, very close friend, Richard Blanche from UK, who is also one of the leaders on optic neuropathy. He was reviewing this article, and we did highlighted some of the concerns when this paper was published, even to Survey, but Survey decided to ignore the comments from Richard and then went ahead and published it. So as Dr. Rajshree pointed out, means studies definitely good, and we need these studies to move forward the literature. If we don't do, and people say there are so many challenges, but unless we do it, we will not know. So that is the first thing for everyone to do similar studies and all. But had it been a different, put it in a different way, so I will say such a study should have been put into form of a narrative review. So there are two types of review article. One is systematic review, meta-analysis. One is a narrative review. Narrative review is you put down all the things, evidences available in the literature, synthesis of evidence without analyzing it, either in the form of narrative review or systematic review, and then you put down point by point, and that's okay, that's enough. When you go to the meta-analysis, so in Oxford level of evidence, if you go and see that Oxford level of evidence, so there are 5 levels of evidence. So systematic review meta-analysis is a very high level of evidence in Oxford level of evidence, and just below Cochrane and randomized controlled trial. So unfortunately, randomized controlled trial is a very challenging thing. So only 2 ways are remaining, is Cochrane thing, which Richard and we have been trying to do that Cochrane thing, but Cochrane means it's at least 2 years of commitment and without doing anything else. So when it comes to systematic review meta-analysis, so that is the closest to the best Oxford level of evidence which you can get. Now, I want to ask Rajshree, do you know something called as a grade? And if I would have missed in your presentation, do you think grade assessment is required? And what does the grade stands for when it comes to such an article? Are you aware?
Yeah, so the studies which were included, so we see that what kind of evidence are they providing. So the studies here, the level of evidence for them is like low to moderate only.
Yeah, the grade stands for grading of recommendation, assessment, development, and evaluation system. So grading, recommendation, assessment, development, and evaluation system. So that is the grade, which is that which we want to develop. So I did a similar studies, and you can look into retinal vasculitis. So retinal vasculitis is like traumatic optic neuropathy. And sorry if I'm digressing the topic slightly away from the traumatic optic neuropathy, but just to give you a sense of, so when we started the topic of retinal vasculitis to identify what treatment, what investigations, and what are the diagnostic criteria we should use, Very quickly, we realized the literature is quite muddy. There is a lot of contamination in the literature because the definition which was used in the literature for defining retinal vasculitis, the treatment which was used, the imaging criteria which were used, all were different. So it was quite different. So very quickly, in matter of 6 months to 1 year, we realized it is not going to be possible to conduct a single systematic review meta-analysis on retinal vasculitis. So we splitted that systematic review meta-analysis into 4. So first one was looking into the epidemiology and the demographics. Second one was looking into the lab investigations. Third one was looking into the treatment and the guidelines and all. And fourth one was imaging criteria and all. So we divided into 4 different things. So here, the fundamental mistake which author did is they did not divide it into 2 different manuscripts. One would have been epidemiology and clinical features of traumatic optic neuropathy that could have stand alone, because each systematic review meta-analysis can answer one question, cannot answer multiple questions. If you have to answer multiple questions, you need to have each one study for each. So they were trying to answer many questions, and then it becomes like this thing. So it is a multi-star, nice Bollywood movie, and then you get multiple star. In the end, it get confused what they are trying to answer. So somewhere they lost the plot. And grade, as you very rightly said, so grade, when we wanted to develop the level of evidence, so there was a risk of bias, and there was again heterogeneity in the study. So in this particular study, if I have to kind of call it as why the grade was low, because the study design was including retrospective and prospective study, there's a risk of bias. Heterogeneity, which you very rightly said, was very bad here. There were quite a lot of high I-square values, and higher the I-square values, that means it's a very significant heterogeneity. There is indirect evidences were there, and which was indirect interpretation, imprecision. So quite a number of things which made the study to very low as far as the evidence is concerned. So based on this, I will probably take it with a pinch of salt, but nevertheless, this has given us a pointer, and I think it is a time when AIOS should gather, and I think Dr. Tanu and the team can start looking into setting up a similar study on traumatic optic neuropathy from their center or with other people involved, and just looking into the evidences related to treatment, and then see whether you have got a good high quality study which are well fitted, and then the heterogeneity can be brought down, and then probably we can be looking into it. Doing a randomized controlled trial, multi-center study, something which we are definitely interested, and very happy to work with any expert neuro-ophthalmologist, whosoever is due. We have a platform ready, and if someone is very keen, we can provide that platform, and hopefully that can answer. Because right now, when we give IV methylprednisolone or we give optic canal decompression, it is all based on all personal experiences and with less evidences. So if you can do that, that will be good. And one last point I will say, when we lack evidence, when we lack consensus from the literature based on a randomized controlled trial or based on publication, one way to move forward is consensus studies. So what we did in ocular TB is we designed Delphi study. So Delphi is a way, so you convene 80 or 100 experts on traumatic optic neuropathy, design a good set of questions, go through that 2 or 3 rounds of Delphi about whether they will treat, not to treat, and that can form the level of evidence which is as good as systematic review meta-analysis. So that can be the future. So those things, Dr. Asri, you can also kind of think about. And I will type one article in the chat group. This article is by Richard Blanche, published in Eye. Very high quality study, only focusing on treatment guideline. And just 3 studies he has included. Very nicely done. And you can read this article in Eye, and then it gives us some idea. But again, the conclusion there is nothing is superior and all. But I think this is a good article, which you should also read it. Yeah, those were some of my points. So any other points, Dr. Tanu or Rasli, please feel free to add. Thank you.
Thank you so much. Any of the panelists or any of the discussants or the mentors, if you have anything to add, most welcome. So
Thank you, sir, for your valuable comments. We'll certainly try to, look more into it. And the Delphi platform that you've told us, I think that's a good way to at least come on to some sort of consensus regarding the treatment protocol.
And you know, in Chandigarh, I do know Government Medical College Chandigarh. I've worked with some people, and even in PGI Chandigarh, there are some people who are interested in large language model. And even in Thapar Medical College, you have Thapar Engineering College. There are good people on artificial intelligence, AI. IIT Delhi has people. You should take help of these people using this AI large language model. They can tease out the information which is published in the literature, and using that LLM model, you can probably get a bit more granular information which a human grader or human reviewer is not able to extract that information. So if you are able to kind of work with them, tell them what are the dilemma you are facing, and you work closely with the engineers, tell them the specific questions. So first thing you should do is looking into the definitions, and then you will realize in 200 articles how many definitions they have used, and then you come up with a single definition. After that, the clinical features for diagnosis. After that, then investigations require, imaging require, and then you go for the treatment. And then they will see what all treatments have been given and what is the outcome. So use AI, and that is the good way to use AI, where AI will access all these published articles, and they will be able to extract the information in more accurate way, and then probably you will be able to come up. So LLM derived AI the review article might be the future for some of those things, because human has some limitation with the human intelligence. We can't do something beyond conventional teaching, but AI can be able to read more into the depth of it. So hopefully that can tell us. I don't know, but that can be one of the future way. And I think with the people around you, the technology people, I think it's the time for interdisciplinary collaboration. You collaborate, and hopefully we can get answers from there, you know.
Thank you, Dr. Agarwal, for those excellent suggestions on how to go forward and take these study questions ahead. So with that, we come to
Thank
the
you, Rupesh,
Thanks.
for the wonderful research insights and a proper analysis from the research perspective for both the articles. Great of you to have joined in spite of not being well. And I hope to see you in OTSI day after.
Yes, sir. I just hope I booked tickets. Just we'll see how it goes. Yeah, just see.
Are you
Okay,
coming
so
to
that-
Jaipur in AIUS?
Sir, yes, sir. As
Conference?
of now, there.
Are you coming to the AIUC?
Yeah, I'm there. But thinking, I've been pressure to cut down my travel. Let's see how it goes. Jaipur is there.
No, we'll ask Dr. Prashant Bhanukule and Namrata Sharma that we should have some dialects on this research methodology.
Yes.
No, we have got
would like to-
talented candidates. All this DNB, I'm seeing they're very good candidates. Only thing is that we need some to give them some directions, and I think these students can do wonderful job. And the only thing is that we just need to little bit spend some more time with them. I think we're definitely happy to help AIOS in whatever way I can. If I'm coming, as of now, plan to be there in Jaipur, but let's see how it goes.
So would like to
Yeah.
compliment ARC, especially Prashant and
Yeah.
Tinku for having
Thank you, sir.
conceived and executed this program so well, and the presenters and the discussants for having brought out some very, very relevant facts and through these and methodology for analysis of the articles, and for Rupesh to have added the fine points about the proper research methodologies and analysis. Great session. Thank you.
Thank you.
Thank
Thank
you,
you
sir,
so much,
always for
sir.
the blessing.
So my compliments
so
to the two
much.
young
Thank
presenters.
you, ma'am.
Yeah, big congratulations to the young presenters, Rajshri and Tanu. They were very well presented articles. And thank you so much, everyone. Thank you all the discussants, Dr. Sanjeev, Dr. Grover, Dr. Rupesh Agarwal, Dr. Tanu, and Dr. Sankita for all your inputs, and to the presenters, Dr. Rajshri and Dr. Vidushi. All in all, a very episode filled with a lot of knowledge and some great interactive discussions. So thank you so much. And just to remind the audience that we'll be back next Thursday with another episode of the AIOS ARC PG teaching program. So do tune in next Thursday at 8 p.m. again. Good night.
Okay, Happy New Year to everyone.
Merry
Thank
Christmas
you.
to
Merry
all.
Christmas once again.
Merry Christmas.
Happy New Year to
Bye.
everyone.
Thank you, sir. Bye-bye.
Thank you,
Bye,
sir.
Rupesh.
Thank you, ma'am.
Bye, sir. Bye.
Don't stay away. Come, Rupesh.
Okay. Okay, sir. Sure. Okay, bye.
Bye bye.
See you, sir. See you tomorrow.
Bye.